Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Happy New Year, new proposed rules, new payment models, new guidance. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Jennifer, and good morning, all. Thanks for joining us. A very full agenda today as we greet the new year. Kathy and I were really proud of ourselves because we had the PowerPoint presentation done last Friday in advance of the holiday weekend. And then, right, Congress stepped in. So we're going to talk about the new legislation that was released yesterday morning at 4 a.m.
Well, and actually, Martie, if I remember correctly, last Friday we had a top 9. And then we all of a sudden had a top 10. And then, now if y'all notice, we're at 11. And 11. I think before this hour is over, we might come up with 12.
I hope not. I hope not, Kathy. But let's dive right in and talk about what Congress is up to and where we hope this all ends up. So I want to take you back to December of 2024. We had a lame duck Congress that was trying to figure out how to avert a government shutdown, which was at that point in time scheduled for the end of December 2024. And they had a lovely piece of legislation ready to go with a bow on top of it. And then President-elect Trump and Elon Musk said, it's too expensive. We don't want to go there. So that legislation blew up. We ended up then with a very slimmed down version of the legislation to keep the federal government open, the American Relief Act, as you may recall, which then extended the timeline for the shutdown to March of 2025. So if you go to March of 2025, we got another bill, somewhat at the last minute, that kept the government open through September 30 of 2025. And then we all fondly remember the fall 2025 government shutdown. What was it, 45 days at the end, Kathy?
Yes.
And we got a deal that kept most of it actually extended funding for certain federal agencies through the end of federal fiscal year 2026. But for the majority of the agencies, the deadline was January 30 of 2026. So now we have Congress back in session, working vigilantly to come up with funding bills for those remaining federal agencies to avoid a federal shutdown. And the one, of course, we were watching closely was the funding for Health and Human Services. What was Congress going to do there? Because we know that's where so many of the programs on which providers rely live. And yes, bright and early yesterday morning, they released the Consolidated Appropriations Act 2026. It covers several, there are 3 bills. It's just CAA 26 is where HHS is included. I think labor is also in there.
Yes.
Is Homeland Security in there? I think they are too.
Yeah, and education.
Education. So we only care about part of the bill, but we're focusing in on HHS. And I think the top line, in my book, the top line is the overall funding for the agency, which came in at $116.8 billion, which is less than a 1% increase over 2025. But however, it is significantly more than had been requested in the president's budget, which had been at $83.3 billion. If you recall, when the president's budget came out last year, sort of in the height of the Doge era, it was calling, again, for this very significant cut of HHS, but also a massive restructuring of the agency, deleting several agencies, consolidating other agencies, creating a different leadership panel and all of that. Congress said no to that plan. And in fact, there are very interesting provisions within the CAA 26 legislation that restricts the secretary's ability to restructure the agency. Any plan for restructuring has to be submitted to Congress 60 days in advance and receive approval. It also restricts the secretary from any sort of unilateral cutting or defunding or altering major programs. Remember last week, it was only a week ago, Kathy, was it Tuesday? There's this big announcement of $2 billion being cut. $2 billion being cut from substance use disorder and mental health programs. And then the next day, no, we're not doing that. But so I think there's some concern about that ongoing, roller coaster ride, and Congress stepping in with very specific provisions in this legislation saying, no more. We have the power of the purse, and we're actually going to exercise it to some degree, at least with regard to HHS. Now, before I turn this over to Kathy to run through the healthcare extenders, I would be remiss to say it's still just proposed legislation. No one has voted on this yet. It was announced as a bipartisan compromise, so both sides have signed off on it, at least in the House at this point in time.
Right.
But as Kathy will tell you, what about the Senate and what about the president? Because again, we thought we had a deal back in December of 2024. We were happy, and it all blew up in our face. So we've had, in the last year, we've had that happen again. We lived through, the One Big Beautiful Bill Act. It changed, it seemed, from day to day as well. So we at least have this tenuous proposal to avoid the shutdown on January 30. And as Kathy will discuss, pretty positive outcomes, I think, for healthcare providers.
I did this little thing here because yes and no. Sometimes when you're going down that yellow brick road, you're going to suddenly hit a tunnel, and the oncoming light, the light at the end of the tunnel, is an oncoming train. So got to be careful. We do have at least one train in this that's coming at us. So from a positive perspective, some of the provisions, and I just kind of laugh when I see this because I guess this would make it 14 years, but those Medicaid disproportionate share cuts that came subsequent to the Affordable Care Act would be further pushed down the road. This is the $32 billion that was supposed to be reduced over 4 years at $8 billion a year. Even those reductions were kept in the One Big Beautiful Bill Act, but this would move forward with pushing them down the road. So it does concern me, as you said, Martie, when I look at that, the expense for that and the expense for this entire package, what will the president say? Will he opt to, don't like that one? Positives, again, would be the Medicare telehealth program, extending the current program for an additional 2 years, which is not really 2 years. It only covers through December of 2027. Hospital at home, 5 years, taking us to September of 2030. Again, kind of off on the year thing. For low volume hospitals, Medicare dependent hospitals, the work geographic index floor, the add-on payment for ambulance services, those are only pushed until the end of this federal fiscal year, which would be September 30th. Becomes an issue that we know hospitals have to deal with, particularly on the low volume hospitals and Medicare dependent hospitals, as it relates to, if things are delayed in terms of those programs being in place and funded, it winds up impacting your overall reimbursement from other payers as well who follow Medicare, getting caught up.
Kathy, before you go to the next bullet, this is my mistake. It's the gypsy floor because it's tied to the Medicare physician fee schedule, which is, if you're a state that has your work RVU,
it's the rural floor. It's the rural floor.
It's the rural.
It's the rural floor for the gypsy.
Yeah, it's the gypsies, the states that have it. Yeah. But it's calendar year because the fee schedule is calendar year. So that should actually say all those other programs through September 30, but the gypsy would be
gypsy. Okay, all right.
December 31st. Okay, sorry. Just want to make sure we're accurate.
Okay, the physician fee schedule, a 3.1% bonus for practitioners who are in advanced alternative payment models would be continued through 2028. I'm going to skip the next one for just a minute. Interesting issue is for Medicare Advantage plans. There's a requirement that they would have to maintain an accurate provider list And it goes on to say that if a patient goes to a provider who is listed in the directory, but is actually out of network, the claim is going to have to be paid as in network and treated as in network from patient responsibility perspective as well. That's kind of a good little, make sure you do it. Restrictions on the pharmacy benefit managers in terms of the programs that they operate and limited opportunities for increased dollars and fraud under that program, funding for community health centers, additional dollars for enforcement under the No Surprises Act. But let me go back to the one that's kind of in the middle. And that is this is the train coming at us. This is the requirement for hospitals to have a separate provider number for all off-campus outpatient departments. So if you have an off-site infusion center, we just went through the issue with the Drug Administration, reductions in payments, they're now going to want you to get a separate provider number for that entity as well. This, again, is going to address site neutral. We do have certain services that are paid at 40% of OPPS to equate to the physician fee schedule. This, I think, opens the door for a whole lot more services to be reduced. I'm thinking particularly some of your imaging services provided off campus, as well as just about anything that you do. But we also run into the issue of getting that provider number and the process it would take. I asked for Martie's input on this. My gut feel, Martie, if this is finalized, the process would be included in the outpatient rule for 2027, outlining what you need to do as a provider and setting up the process. I can't picture them doing it any sooner than that.
I can see them setting up the process and saying, oh, by the way, we're going to end the differential payment for grandfathered outpatient.
Period, across the board, not just Drug Administration. But I can also see them, actually the rule for getting the provider number, the rule itself, would actually come out as a part of the outpatient rule for 2027. What's missing? There is absolutely nothing in this legislation related to subsidies under the Affordable Care Act. We've been looking for it. We've been thinking that Congress was going to step up and do something. It's not there.
The House passed it.
The House did, but nothing from the Senate. Yes.
So what's happening? I mean, this is the big prediction, and this is what the Democrats were saying when they were during the shutdown, was if you let the ACA subsidies expire, you can end up with millions of people that are uninsured. So, Kathy, we're starting to see the data on enrollment in ACA plans.
Yes.
The actual drop dead date was last week for enrollment in those plans. And what do they look like? I know you've been tracking this because you send me these messages. So where are we at?
Well, currently the report that has come out says that enrollment is down about 3.5% for 2026 compared to 2025. There was a great report that was published actually by Becker's recently that addresses enrollment. And what's amazing to me, they listed it by state and where is a particular state in terms of above or below 2025. New Mexico is a positive 19.5% in enrollment. Why? There was additional funding that was made by the state, is my understanding, to help individuals maintain coverage. Next down is the District of Columbia at 9.7%. So from 19.5 to 9.7. On the bottom end of the list, we're looking at North Carolina with a reduction in enrollment of a negative 21%. The problem is, Martie?
Well, you can enroll, but you got to pay, right?
You got to pay, Go ahead.
Well, I'm just saying, my 28-year-old 28-year-old son who went on the exchange in New York called me this weekend, like, I've got to pay this bill now. I'm like, yes, Jack, it isn't just sign up. You actually have to pay monthly. And that's going to be the question, because I suspect there were a lot of folks that signed up for and enrolled in an exchange plan thinking that the subsidies may be extended. And so as how we say, holding their place in line. So the rubber meets the road next month, where we start getting the data on how many folks actually paid their first month's premium and in fact secured coverage. So we have people in line. The question is, they actually going to walk through the door and pay the premiums? And that's what we'll be watching really carefully. So they're going to be more like North Carolina. We're going to see numbers more consistent with North Carolina on a nationwide basis. So it ain't over yet, I guess is the best way of putting that.
Yeah, I think it is very concerning in terms of what happens, and then providers who are treating patients who appear to have insurance but might not have made their premium payment.
Yeah, exactly.
But when the bill comes due. So very concerning, and something that we need to take some time to look at. Now we're going to jump into a whole bunch of hot topics, things that are going on. So let's start with the infamous transparency and coverage regulations. Transparency and coverage applies to the required reporting of negotiated rate information on the part of the plans. It is what the plans report. There was a proposed rule on this that was issued in December, with comments due February 21st. The idea behind this is to improve the usability of the data. I don't know if anyone has tried to look things up in the transparency and coverage data that has been posted by the plans, but it is very intensive in terms of the amount of data that is there, and very hard to access, and in many instances is not even posted by a provider number, but actually by a tax ID number. So that becomes very hard to look at. Some of the provisions that they are looking at and including in this modification to transparency and coverage is one that has been addressed a lot in terms of the plans who have posted negotiated rates for providers, practitioners, for services that they would never provide. So a podiatrist doing cardiac surgery. They might have a negotiated rate, but if they are services that the provider is unlikely to perform, they need to be removed from the listing of services. The reporting time frame for the plans is going to jump from the current monthly requirement to a quarterly requirement. They are to report by provider network rather than plan or policy. They're going to have a requirement to maintain and keep posted change logs and utilization files. They're going to have modifications to the reporting requirements as it relates to out-of-network pricing. If this particular service is provided and the provider is out of network, how do you price that? That would need to be posted by the plans. And one area that I think is very interesting, and I'm really trying to figure out how they're going to do it, is the same information that they would be posting online for this information. They're going to have it available in print and provide it by phone. So I can picture someone, Martie Ross, picking up the phone and calling a major payer and saying, can you tell me how much you pay the following 10 providers to get contracted rates? It would be very interesting to see how they would provide that information by phone.
And Kathy, in TIC, I love that, one of my faves. In TIC, it's all healthcare providers that they have contracts with, right? It's not just hospitals, right?
Right.
So,
this is absolutely. It's the dentists, it's the physicians, it's anyone that they have a contract with. Therefore, it's a massive, massive file.
Right, because we know that the hospital price transparency files are huge, and we don't have requirements, applicable to other providers that they post their data, but we're going to be able to get this now through the insurance side. Interesting.
If I remember something that our partner Jason Harden posted a year or so ago when we were looking at this data, just one payer posting their information, one of the large payers, the amount of information there was greater than the information contained in the Library of Congress and Wikipedia. So it's big. So they're trying to streamline it and make it easier to use. This will be fun to see. The comments will be great to read. So stay tuned. Moving on. Here we go. Medicare Advantage. Let's take a quick look at Medicare Advantage and the proposed rule. Also some other updates on the MA program. There was in November a proposed rule. This is the 2027 technical changes for the MA plans. We wanted to raise this because it is, I'm very focused on this particular issue and frustrated and urging providers to submit comments. My main area of concern within this rule was a proposal to modify the star ratings, the measures, the quality measures that go into establishing the star ratings for the plans. You know, it is their star ratings that addresses the dollars that they would receive to be able to provide supplemental benefits. What they are looking to do is remove a number of process-heavy or administrative measures. They want to focus on outcomes. We've given you kind of an idea in the slide in terms of some of the things that they are looking to remove. Things such as appeals timeliness, complaints, the accuracy of their plan finder. This should be Maximus, M-A-X-I-M-U-S, concurrence rate. So when there is something goes to dispute, and Maximus makes a determination as to whether or not the plan was right or the provider was right, they would be looking to eliminate that concurrence rate based upon those decisions. Whether or not the plans are providing eye exams for diabetes, patient experience measures such as members leaving the plan. All of those things would no longer be included in their actual quality measures. My perspective is that removing these measures is going to weaken both provider and patient ability to influence the plan behavior, and it weakens overall oversight and accountability on the part of the plan. So I do urge you to think about commenting on that particular rule.
So, Kathy, when you say outcomes measures, we're talking about, what percentage of your plan enrollment has an A1C of X?
Exactly. Yeah.
So it's basically how good their network.
Diabetics, did you make sure that they received eye exams?
Are those things providers do, not plans?
But the plan.
Okay, I'll leave it at that. It's
yeah.
If I'm choosing a plan, this is the stuff I care about.
The plan encouraging and seeing that patients have this done. This is something that the plans report on.
Yeah. So I guess the flip of that is if the outcomes are going to be more front and center, it is an opportunity for providers to, extract their pound of flesh in terms of negotiating better rates if they can demonstrate the outcomes that will drive star ratings.
Well, and then let's take it a step further, because on this slide, I say one of the areas that would be removed would be complaints. These are complaints filed both by patients and by providers. So meanwhile, we got this rule sitting out there, but about 2 weeks ago, CMS came along and they have implemented a new Medicare Advantage complaints tracking module. We had something that came out maybe a year and a half ago that was a form that you could fill out and submit. They have now actually converted this into a tracking module, a portal. We've given you the link on the slide where you can go in and actually complete this form. But you're going to go in, you're going to talk about who you are, who the patient is, who the Medicare Advantage plan is, what happened, and you can provide claim number and dates of service. CMS is going to be reviewing these, and they will be moving forward with working with the plans not to come to resolution, but to encourage the plans to engage with the providers. That's what they do with the form that they have now. The issue is we had this proposed rule saying we're not going to be looking at complaints for star measures, but then they turned around and immediately issued this. So what are they going to be doing with this information? And I think the fact that they have moved forward with implementing this, tracking this portal for this information, I think it does give you the opportunity, if you comment on the rule, to say you need to at least allow this portal to run for a year and see what kind of volume is before you remove complaints as an issue. Martie, MedPAC?
So while we're on the subject of Medicare Advantage, last week, I think January 16, MedPAC received a report, or one of its regular annual reports regarding the status of Medicare Advantage. And we always like this report because it's the one that focuses in on a comparison of what the federal government spends on a traditional Medicare beneficiary versus what the government spends on an MA beneficiary. And what the study does each year is account for what's self-selection. So healthier people tend to enroll in MA plans. And so how could you even and level the playing field so you can assume the same level of risk in both populations? That is referred to as selection. And then we have the issue of coding intensity, the ongoing issue of coding intensity, where Medicare Advantage plans, because they are paid based on the severity of their population, they code up patients and add and assign ICD-10 codes to patients to try and increase that. If you've been paying attention, was it Kaiser Permanente just settled one of the largest MA claims, like several millions of dollars paid back to the federal government because of coding discrepancies in their coding patterns. And it's Kaiser Permanente. I mean, they're not publicly traded. And they're supposed to be some of the good guys owned by the providers, and yet they're getting in trouble with this. But what you see is that we're still paying $76, significantly $76 billion more for the Medicare Advantage population as compared to the traditional Medicare population. And Kathy, what was it supposed to be when we first came up with this idea of Medicare Advantage?
95% of Medicare.
Right. So we are significantly above that in terms of this Medicare population, and certainly ready for reforms. But again, we get a proposed technical rule that instead focuses in on the star rating system. What we will see tomorrow, and I'm looking forward to this, is all the big health insurance executives are up on Capitol Hill for two sets of hearings. I think they have the House in the morning and the Senate in the afternoon. And the topic is sort of the cost of health insurance in America. And certainly this MedPAC report is going to play a role. Obviously, public sentiment regarding health insurance costs is going to play a role. But it's certainly going to be something worth paying attention to. If anything comes out of that, other than just grandstanding, I hope there's more there, but start looking for some real solutions to these issues.
And Martie, before you go on, I took a minute to look at the questions that have come in. One I just want to comment on, and it was the question related to the commenting on the proposed technical changes. The comments are due Monday, the 26th. So for that person and for anyone else who would like to comment, while you go ahead, I'm going to very quickly put the comment address in the chat, in the Q&A, just because I think it is so important, and I apologize that it wasn't on the slides.
Thank you, Kathy. Our friends at the CMS Innovation Center were very busy through the holidays, releasing several new proposed alternative payment models. Remember, the Innovation Center effectively does pilot projects. And most of those projects, you have the opportunity to enroll to participate. And it was several of those initiatives were announced just relatively quickly review. I mean, talk about a lot of acronyms. They've got to be running out of words to use for acronyms at this point. But we've got payment models that are focusing on integrity in the traditional Medicare program. That's the WISER model that was introduced last year. But this introduced prior authorizations into traditional Medicare for certain types of procedures in certain states. So that was set to launch on January 1st. A big focus on reducing drug costs. We have 4 different models that have been introduced here: Generous, Guard, Globe, and Balance. Not directly impacting providers so much, but again, the broader impact in the industry trying to bring down drug costs through these innovation models. We've got lifestyle and functional medicine interventions. That would be the MAHA Elevate. This is a limited number of opportunities for a few states. I can't remember if it's like 2 to 4 states that'll have the opportunity to participate in this model, which is going to focus on the impact of functional medicine, lifestyle coaching, and the like on total cost of care. Providing outcome-based payments for chronic disease management, the access model, which I think is sort of the big deal right here. And it's going to be very interesting to see how this one rolls out. It was announced in, I think, right around Thanksgiving. The Innovation Center released the actual request for applications in mid-December. Those applications are due in April, early April, for a program that starts on July 5. What access, and we're certainly going to spend some more time on access through HCRR, but this is a model that allows a Part B provider, you have to be enrolled in Medicare, to provide a range of care management services for beneficiaries with certain chronic conditions. There's a specific list of chronic conditions, and receive payment for providing that care management service. That payment, however, is adjusted based on outcomes that are very direct outcome measures that tie to the severity of a particular chronic condition and whether that is effectively being managed. There's also an adjustment to payment based on whether that Part B provider is appropriately managing the patient in terms of other services that they receive, because the payment's reduced if they're receiving complementary services from another provider. In this program, there is also an opportunity for primary care providers to receive a care coordination payment. So if they receive, if this Part B provider that's performing care management services, the access provider pushes certain information to primary care providers. If that PCP is reviewing that data, then they have an opportunity to receive a quarterly payment as well. Access also addresses the issue of copays and deductibles, because it allows the access provider and the PCP to waive copays and deductibles, so eliminate that barrier to care management services. This all sounds good, right? This idea of incentivizing the kind of centralized care management services. Question is the marketing to beneficiaries, because these access entities, these Part B provider access entities, will be subject to traditional Medicare marketing rules, which are the rules that apply to MA plans. So we have folks out there marketing aggressively to these Medicare beneficiaries to sign them up for care management services, not with their primary care provider necessarily, but kind of an unalignment there. Now, certainly, ideally, we have relationships that develop between primary care practices and these access providers, or these primary care practices become access providers. So it is sort of a continuum of care. But I think there's some mischief here, potential of companies really exerting a great deal of intense marketing pressure, signing up beneficiaries, getting these services, and ending up with some lack of coordination with primary care providers. So watch this space carefully when it comes to access. We have the ACO REACH program is sunsetting at the end of 2026. And so CMS in December announced the replacement model, which is the LEAD model. I don't remember what it stands for, but the LEAD model, I don't remember what REACH stands for either. So it becomes the acronym, right? But the LEAD model is intended to have some significant refinements to the calculations of benchmarks and intended to eliminate some of the issues in benchmark calculations that negatively impact providers that receive add-on payments or cost-based reimbursement. So think of your critical access hospitals, your RHCs, your FQHCs, your Medicare dependent share, your sole community hospitals. All of those folks receive add-on payments that make them, the cost is higher to receive services from those providers. So they have been sort of on the outs when it comes to ACO models. LEAD promises to address those issues to encourage greater participation by those types of providers in the program. Again, devil in the details. We're still waiting to see the request for applications for the LEAD model, but it would start January 1st, 2027, again, replacing what had been the ACO REACH model. And then in terms of engaging specialists for physicians in mandatory alternative payment models, we'd be remiss but to remind you once again that on January 1st, 2026, the TEAM model started. That is the episodic payment model applicable to hospitals in 25 selected CBSAs, where they are now financially responsible for total cost of care 30 days post-procedure. And then we have going live in January of 2027, the ambulatory specialty model, which is focused on lower back pain and congestive heart failure. And physicians who care for those patients, putting them in what I call really kind of MIPS on steroids, because it's using very specific quality measures, cost measures, promoting interoperability, as well as improvement activities, very specifically defined. Then for those physicians that end up participating through this model, comparing them and varying their prices based on where they are in that continuum. So again, we're waiting to see the CBSAs that are selected for this model. We're saying something around 25% of cardiologists, and then those folks that also treat folks with lower back pain, whether that's anesthesiologists, orthopods, and the like. We'll see their selection there. Bottom line here is this kind of aggressive approach by CMS Innovation Center looking for new models. Shame on me. I should have slipped the slide over to more details on the access program. So you have these for reference. And then also the LEAD model, the enhancements there. I just got talking too much and forgot to flip the slides, and I apologize for that. So Kathy, why don't we take it over to you on the interoperability rule?
I wish you wouldn't. Neither Martie or I are experts on health IT, nor do we ever want to be experts on health IT.
What do you want it from two women whose ages add up to 150 something, right?
Yeah. However, what we will say is we like to read rules. So when things get slow and they publish something, we're going to go read it. So we try. Not an easy rule to read. So I envy those of you who are really into this. But we had both a proposed rule and a withdrawal notice published on December 29th. Unfortunately, they weren't withdrawing the proposed rule. They were proposing something, withdrawing something they had already done. So what they withdrew was the rule that came out about a year ago. This was the Health Data Technology and Interoperability Patient Engagement Information Sharing and Public Health Interoperability Rule. It was affectionately known as HTI-2. That basically removes, and what they're doing is removing those provisions that have not been implemented. And because of the issue of cost, and also because they were very complex and not easy to understand what was expected to be done. These are going to be your proposals related to encryption and decryption of electronic health information, the implementation of APIs to ease a data exchange between the payers and providers, and the whole issue of public health data exchange. Those are being removed. When the rule was published in the Federal Register, which was December 29th, the withdrawal was effective. So those rules no longer out there. You don't have to be looking for when are they going to finalize this. But they also move forward with what they're calling HTI-5, Health Technology and Health Data Technology and Interoperability number 5. Tells you how many rules we've had. Comments on this rule are due February 27th. Essentially what they're doing here is removing about 50% of the existing criteria for certification, revising a number of others. If I remember correctly, 34 of 60 criteria are being removed and 7 are being revised. The intent is to transition to FHIRS, APIs, the Fast Healthcare Interoperability Resources program. So this would address patient access, electronic prior authorization, and public health reporting. They would also move in this rule to strengthen the rules against withholding electronic health information, and they would modify the definitions of access, use, and exchange. They want to include automated means of access of information. While we're on the issue of health IT, real quick, just wanted you to know that the breaking news this morning was that if you remember about a year ago, when as we moved into the current Trump administration, they ended the Health Information Technology Advisory Committee meetings, the high-tech meetings. Well, they, as of this morning, have now announced that there will be a high-tech meeting scheduled for mid-February, February 19th. So it will be interesting to see as they bring that committee back together how they start looking at this rule and its actual implementation. So something to monitor, something to keep tabs on. Martie, you were going to say.
It's just interesting because, go back to 2009 with meaningful use, the dollars available. And I think kind of hindsight's 2020, but I think the universal criticism at this point is why the meaningful use requirements did not focus on interoperability. Granted, you could make the argument that the capabilities were not yet available in the market, but what better way to drive the development of those capabilities than having included those in MU? So it seems like now this rule, HTI 5, what happened to 3 and 4? But I'm not going to ask. But with HTI 5, it seems like we're finally correcting that original sin that we kind of bought ourselves back when we started down this road of really full-scale implementation of electronic health records, and really hopefully now seeing the promise of this. So I think these are wins. I mean, they're confusing. They're confusing as all get out, and I just get lost in them. But kind of at the top level, I think there's some real promise here.
I think the main issue from my perspective and from a comment perspective is when you start looking at timeframes for compliance and implementation, particularly when we look at rural providers, they really need to look at what they can do and how quickly they can do it.
Yeah, because it's going to push rural providers off of, rural providers are notorious for having kind of the one-off EHR system, right? They're not buying the server or the Epic. Yeah,
we need staggered time frames.
Yeah, that's going to be a challenge right there. This is a proposed rule from December 19th to include new provisions in the conditions of participation for hospitals, specifically prohibiting hospitals that participate in Medicare and Medicaid from offering, facilitating, or performing sex-rejecting procedures on individuals under the age of 18. Sex-rejecting procedures is defined both as pharmaceutical as well as surgical interventions, and there are very narrow exceptions included in the proposed rule on medically verifiable sexual development disorders or for treating injuries or complications caused by prior procedures for the individual. Because this is tucked into the Medicare conditions of participation, that means non-compliance with this COP would result in termination of your provider agreement with CMS. So this has always been the most effective tool available to CMS in terms of regulating hospitals and other types of providers by including things in COPs. But COPs typically have been standards of care. It's like this is what your quality committee needs to look like. This is how you address infection control. These are the standards for your medical staff. This is really, I think, the first time we've seen the COPs go to a thou shalt not perform a particular procedure. Again, comments are due here by February 17th. I think I checked on Monday if they were already up to about 2,500 comments that have been submitted, which is usually you see all the comments showing up the last couple of days, but there are already a number of comments on this particular one. There is also a separate proposed rule to exclude gender dysphoria from the definition of disability. The reason for that is to ensure that this COP doesn't end up violating the Rehabilitation Act. So that's just sort of a cleanup job on the part of CMS. So they were certainly well prepared when they issued this on December 19th. That would be the Friday before Christmas, in case you were wondering. Initial guidance on Medicaid work requirements or community engagement requirements, pick your title there. If you remember, our good friend, the One Big Beautiful Bill Act imposed these requirements for the expansion population. So those states that have expanded Medicaid, for that population, we now have requirements for either working a certain number of hours, engaging in community activities, being in any type of qualifying activity. And that's what part of this informational bulletin that came out on December 8th was focusing in on what are those qualifying activities. And so we have clarification for the states there. They also, in this memo, in the informational bulletin, made clear that it's going to be the responsibility of states to independently verify compliance or whether an individual is engaging in a qualifying activity or meets an exception from having to engage in a qualifying activity, such as they are medically frail, they have children under the age of 13. But now it's going to be incumbent on the state to verify this information as opposed to simply relying on what the Medicaid beneficiary or the applicant tells you their status is going to be. There was dollars included in the bill that would pay for states to implement technology necessary to support this. And certainly the question now is that going to be enough given these individual verification, these independent verification requirements? The other issue that this raised that a lot of folks have been commenting on is what do we do with medically frail individuals? Because remember, the statute requires that an individual has to engage in a qualifying activity or be exempt the month prior to enrollment. A lot of folks that we end up needing to qualify for Medicare because they've had a significant traumatic injury or a significant diagnosis, and they'll qualify thus as medically frail and would be exempt from these requirements. But they wouldn't have been medically frail the month before. And so there's a lot of question of being raised by a number of states saying, hey, CMS, you got to give us some guidance here because these are massively expensive patients, right? It's like the reason you're getting them qualified for Medicaid at the hospital is because you're about to eat a ginormous bill for a condition that rendered this individual medically frail. But if they didn't meet the qualifications the month before, does that mean I effectively have a month of non-coverage as a result of this? And this is just an example of the level of complication that's going to have to be addressed when CMS publishes what's going to be an interim final rule by the 1st of June, directing the states of how to implement the work requirement / community engagement requirement. And they also promise that in addition to that interim final rule being issued by the beginning of June, there will be additional guidance coming out to the states. One last thing that's clarified in this informational bulletin is the exemption. The statute included a 2-year request for extension for states. So if states are making good faith progress in implementing the work requirement, they can push the effective date from January 1, 2027 to 2028 or 2029. So to give them sort of a longer leeway to move forward. This bulletin makes clear that CMS is only going to grant those extensions if there in fact is evidence of meaningful efforts towards implementation and that the state is experiencing some severe or unexpected issues that are hindering progress. So it's just really hard to do this because it's complicated. It's going to have to be something more that's preventing the state from moving forward. So stay tuned on that as we see in 2026 this movement towards implementation of these standards. Kathy, finally a good time that we live in Kansas and Florida, non-expansion states, because on top of everything else, at least our state Medicaid agencies are not struggling with implementing.
They're not struggling with this, and our enrollees do not have to. But you've got states who could, Kansas and Florida as non-expansion states could implement this at a state level.
Right. Georgia. Remember, Georgia did this. Georgia went down this road.
And therefore, maybe we shouldn't say it out loud.
Okay. I just jinxed it. Darn it.
Yeah.
The other issue that hospitals have got to get their hands around is, when we have work requirements, we anticipate that's going to be fewer people that are going to qualify for Medicaid, which means that is going to impact a hospital's Medicaid dish percentage. And so this goes to the Medicaid ratio that's calculated. And there's provisions in the CAA 26 that I just didn't understand, Kathy, about how we calculate Medicaid days. But that formula, however it ends up, comes down to how you had individuals at your facility who you provided services for that either that were eligible for Medicaid but not entitled to Part A. So these are the non-dual eligibles. You take the number of days of inpatient for those patients, divide by the total number of days. That gives you your dis percentage. Why do we care about this number? We care a lot about this number,
Right?
Because first of all, it's your add-on payment that you receive, and so as that dish percentage goes down, your add-on payment goes down. But more importantly, is the impact on potential 340B loss, and we're already seeing this happening, is that if you have to have a dish percentage at or above 11.75 for a hospital to qualify, a PPS hospital to qualify for 340B. There's sole community hospitals, rural referral centers, that percentage goes down to 8%, but then of course they don't have access to orphan drugs as a result of that. But there are a number of hospitals sitting on the edge that with loss of Medicaid days, that they could see no longer qualifying for 340B. So now is the time really to be looking for potential solutions to this. One is running Medicaid eligibility checks as late as you possibly can when you do your cost report, because there's just going to be a greater likelihood that an individual will have qualified for Medicaid. If you wait, the longer you wait, because the state just takes longer to make those eligibility determinations, you're more likely to have individuals who qualify. So that's one administrative solution. The other is Medicaid eligibility for out-of-state patients. And if you've got a patient from out of state, we sort of just kind of not dealt with that previously, but now the question will be, do I run data on those patients as well?
Well, and it's not necessarily just the patients who are from out of state. They have an address here, but they actually qualified for Medicaid in another state. And we don't tend to ask, where did you live 3 months ago? We ask, where did you live now? And their Medicaid within that other state is valid now. And do we have it? Do we have that information?
Related to that is just making sure you're capturing good demographic data. So this is all kind of registration. This is all circling around registration to get that data as necessary that potentially could result in more qualifying days. And then, what we hear a lot of hospitals doing is, how can I increase my Medicaid days? I'm looking at programs that have high Medicaid percentages like OB, like psychiatry. Careful with psychiatry. Remember, if it's a distinct part unit, you don't get the credit to your hospital cost report for those Medicaid days. They'd have to be psychiatric beds within the hospital itself, not in a DPU.
And for that, you're really going to have to weigh adding OB and psych, because those are also areas that could have significant number of uninsured individuals with no payment.
Yeah,
and exactly. So it's a question of going to have to do some balancing there.
Right. And remember, geriatric psych doesn't do you any good, because those folks are most likely going to be dual eligibles, and they don't count towards the days either. So everything in motion. Kathy, talk about more 340B stuff.
Well, this is the outpatient drug survey, affectionately known as ODAX, that has been introduced by CMS, actually required by the administration in April through an executive order. And the idea is to establish what is the acquisition cost for drugs that are separately payable under the outpatient prospective payment system. This goes back to that 340B litigation from a few years ago, where the reduction was for 340B drugs was average sales price minus 22.5%. And the hospitals argued that, what is the validity of the minus 22.5? Where did that number come from? The court said that CMS could not do that without a survey. Now we're doing the survey. There was a requirement, and again, this is for all hospitals that are paid under OPPS. I'm going to tell you how to find out if that means you or not, just a minute. Registration was from December 9th through December 31st, so hopefully you have registered. You need to identify a point of contact and a submitter. They can be the same person, but you have to start with the point of contact. The reporting period, the time period you have to report the information is from January 1 of this year through March 31st of this year. You're using a data period which ran from July of 24 through June of 25. If you want to know whether or not you are required to participate, there is a link on the slide. You can look yourself up. Essentially, this is it listed in provider number order. So you can take a look at whether or not I am required to do it. The idea is that they want this information, they want it as quickly as possible because they would plan to use it in calendar year 2027 proposed rule to set the rates for these separately payable drugs. There has been a lot of discussion about the reporting process. There is a detailed listing of all of the national drug codes that need to be reported. These are the separately payable drugs, so that it's actually listed as an Excel spreadsheet, so you can go in and do your research in terms of the amount that you were paid. But the dollars that you're reporting at the national drug code level would be inclusive of all discounts and rebates. There is a concessions tab, not for popcorn, but it is a concessions tab that allows you to indicate any savings that you got as a result of a group purchasing discount that was not applied at the individual national drug code level. You would be reporting for each of the drugs, the units purchased, 340B and non-340B, the net acquisition cost, 340B and non-340B. There is concern over, do I really need to report? I mean, do I really have to do this? It has been said that CMS cannot require you to do it, and that perhaps is true. However, they can cause impact to those who do not report. They said that they can't force you to complete the survey, but we may consider non-responses in future rate reductions. In an FAQ, they said that we would look at how non-compliance could be reflected in that hospital's future payment rate. And in the final rule, they actually said that one of the things that they were considering is for those non-responders, we would not pay you separately for 340B drugs on which you didn't report. They would be bundled in to the APC for the service provided. So very concerning in terms of, do I have to versus what happens if I don't? So, Martie?
Yeah, I think it's good. We made it through 8 of our 11 topics. Let's blame it on Congress that we spent more time on the first topic. But the last 3 topics we were going to cover, you have the slides. They provide the information necessary. But we're trying to do our best. Our New Year's resolution was not to run over on these webinars. So it's clearly a busy time. We're watching carefully. But thank you for joining us. And again, happy 2026, Kathy.
And if you do have questions on those last 3 sections, please put them, even if you can't put them in the chat, you've got our email addresses. Email us and we'll be glad to respond.
Jennifer, back to you.
All right, thanks to our presenters, Martie and Kathy. So the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. On behalf of PYA, thank you for joining us. Have a great rest of your day.